All right, so good morning. It's great to be talking to a group of like-minded physicians. And my name is Georgia Eade. I'm a psychiatrist at Smith College, which is an all-women's college in Western Massachusetts. And prior to that, I was a college psychiatrist at the Harvard Student Mental Health Service for 7 years. So I have a lot of experience in college mental health, but I've also practiced in other settings, clinic settings, and private practices over the years. But right now, I'm solely a college psychiatrist. So you might be surprised to find that this talk is mostly about Alzheimer's disease. And so why am I talking about Alzheimer's disease when I treat people who are very young? And I hope that the answer to that will become obvious as we go along. I am unconflicted, at least financially. So this is how the talk is going to go. First, I'm going to talk about brain fuel utilization. Then I'm going to talk about memory, how insulin and glucose affect memory. Then the little we know about how insulin and glucose affect mood. And then some dietary intervention, some interesting thoughts about dietary intervention in mood and memory disorders, which I hope to convince you by the end of the talk are metabolic disorders. So what does the brain like to eat? The brain is greedy. Even though it takes up only 2% of the body's weight, it's at least 20% of the body's glucose supply is taken up by the brain. And why is that? It's because the brain requires a steady supply of high quality, rapidly utilizable energy, preferably in the form of glucose, to do its job. The brain is an electrical organ, and it requires a lot of energy to do its work. It's particularly the glutaminergic neurons. These are neurons in the brain which produce the excitatory neurotransmitter glutamate. Those require a lot of energy. And so it is true, the brain does need glucose, and as all of us hear far too often, that must mean that we need to eat sources of glucose to keep our brain functioning. If I don't, Dr. Reed, if I don't eat sugar, how is my brain going to work? And of course, we all know here that it's very easy to generate glucose from protein in the liver, and you can do it smoothly, efficiently, and quite safely if you don't eat too much carbohydrate, actually. So why does the brain need glucose? It's because, fatty acids, which the rest of the body, much of the rest of the body likes to burn, can't be burned by the brain. They can get into the brain, contrary to popular belief. They do cross the blood-brain barrier. But the mitochondria in our brains do not have the enzymes needed to burn them, and they're slow to burn. And ketones, are, by comparison, which are breakdown products of fat, are clean and efficient, but they can only provide a maximum 60% of the brain's energy supply. And I became curious about why that is. I've heard that number so many times. Why is it that the brain can only, the brain still, under the best of circumstances, still needs 40% of its energy to come from glucose? And there are two reasons. One is those glutaminergic neurons I was telling you about, the excitatory neurons. They require very rapidly utilizable energy, and glucose is the fastest energy source you can have. The other really interesting reason is that some nerve cells have very long processes that become extremely narrow at their tips, and there's no room out here for mitochondria. So there are many places in the brain where you have to use glucose because ketones can only be used by mitochondria. So gluconeogenesis, we talked. So if the brain needs a lot of glucose, why not just make sure that it has all the glucose it always needs and eat as much sugar as possible? Well, first of all, we don't need to do that. But there are some other really important reasons why you might want to consider where you get your glucose. Very interestingly, I didn't know this, that whatever your blood glucose is, your brain glucose is only 60% of that, but it's a linear relationship, and it's been shown to hold true even up to blood sugars as high as 400. So the more sugar you have in your blood, the more sugar you have in your brain. And how does glucose get into the brain? So this is the blood-brain barrier here, and these are little glucose molecules, and these are little GLUT1 receptors. These receptors do not require insulin, so glucose has no problem getting into the brain. It needs no help. And then once it gets into the brain, most cells in the brain use GLUT3 receptors to get the glucose inside the cells so that the cells can use the glucose for energy. And these receptors also do not require insulin. So glucose transport, insulin not required. So what are all of these insulin receptors doing throughout the brain? There are lots of them, and they're especially dense in the hippocampus, which is going to be our star of the show today. We're going to talk a lot about the hippocampus. This is where memories are formed and emotions are processed. So since we're talking about memory, we'll be talking a lot about the hippocampus. It is very rich in insulin receptors. So what is all this insulin doing in the brain if it's not needed to get glucose into the brain or to its cells? What it's doing is a lot. So really important things. It is responsible for the metabolism of all the macronutrients. It is responsible for maintaining brain energy balance and body energy balance through the hypothalamus. And it's responsible for nothing short of cell growth and survival. Insulin, as a reminder, is a growth hormone. It's not simply a glucose regulator, not in the body and not in the brain. It's really one of the least of its jobs, one of the least important of its jobs. So in short, the brain needs insulin, and without insulin, brain cells can't use glucose, and if you can't use glucose, brain cells will fail. So how does insulin get into the brain? It's a little different. There are insulin receptors on the blood-brain barrier, but different from glucose, these have a saturation point. So a certain amount of insulin can get through, but then at a certain point, no more can get through. And then once the insulin does get into the brain, it attaches to insulin receptors on cells and regulates a whole host of metabolic activities within those cells. So again, insulin transport is saturable, which is not true of glucose transport. So that's how the normal mechanism looks. You've got insulin, you've got glucose, we know how it gets in, we know what it's doing there. But what about an insulin resistance? So we know a lot about insulin resistance in the body and how it eventually can lead to type 2 diabetes. But what about insulin resistance and the brain? And this is a fairly new area of research, and a lot of excellent studies have come out about insulin resistance and memory that I found fascinating. So here's our friend the hippocampus sitting in the medial temporal lobe, processing our emotions as we speak. I hope all of your hippocampi are functioning well. And these are the things that it's responsible for. And now, I know that hippocampus is Greek for seahorse, but I couldn't resist. I decided our story needed a sympathetic protagonist. So the hippocampus is very vulnerable to damage, metabolic damage. Why? Because it is extremely reliant on glucose. It uses a lot of glucose. It's a glucose hog. And it's exquisitely sensitive to insulin. It has the highest density of insulin receptors in the brain. And it is one of the very few places in the brain where newborn neurons can be generated, even in adulthood. And interestingly, I guess not surprisingly, the hippocampus, the hippo is the first to go in Alzheimer's disease. Well, actually it's a locus coeruleus, but that's another story. But this is what we notice. We notice memory deficits. And so it's one of the earliest detectable traits of Alzheimer's disease. Why is it so fragile? Again, it uses a lot of glucose. Remember, our glucose and insulin coming through here and coming up to the brain cell. If this is a brain cell from the hippocampus, in addition to GLUT3 receptors, which do not require insulin, GLUT4 receptors do use insulin. And what are these GLUT4 receptors doing on this hippocampal cell? The GLUT4 receptors, only a few types of cells in the brain have GLUT4. What this does is it helps the hippocampus get extra glucose at times of extra need. And without insulin, this doesn't happen. The bottom line is memories require insulin. And the hippocampus can extract extra glucose beyond the concentration gradient that we were talking about before when it needs extra energy. So this is, we all in this room anyway know that it can be dangerous to overeat carbs. I mean, if our brain needs a lot of glucose, why not just give it as much as possible so that we'll never run out? And the reason is because if you eat too much of the wrong kinds of carbohydrates for your metabolism, you can develop insulin resistance, where in order to keep your blood sugar in a normal level, your insulin levels have to rise. And then over time, the end stage of that process is that insulin starts to wear out and you can't keep your blood sugar in a normal range anymore. But this is the phase we're really interested in because there's a lot you can do to prevent this process from happening. So this is what it looks like. Insulin resistance in the brain looks like this. Glucose levels will match what's in the blood, 60%. Insulin levels will level off. One of the reasons why it becomes difficult to get insulin into the brain in the case of insulin resistance is because when you flood the blood-brain barrier with too much insulin, so in the case of insulin resistance, your insulin levels are too high in the blood. Your blood glucose starts out as normal, but your insulin is too high. So it floods the blood-brain barrier and saturates all of these receptors, and over time these receptors start to downregulate. And so you start to have fewer of them, and it gets harder and harder over time for insulin to get into the brain. And these GLUT4 receptors, which the hippocampal cells rely on to build memories, don't work well without insulin. So what you have is this paradoxical situation where you've got plenty of glucose in the brain, but not enough insulin to use it. And this is called glucose hypometabolism. And it can lead to all of these different consequences. Not enough energy, oxidative stress, because one of the things that glucose does is it generates, when cells use it, generates antioxidants and lower glutamate production. That's the excitatory neurotransmitter. So what's actually happening is, paradoxically or ironically, your brain has plenty of glucose, but it's starving to death because insulin can't use it. How do you know if you're at risk for Alzheimer's or one of your patients is at risk for Alzheimer's? We all are familiar with these risk factors: age, family history, ApoE4. You can't do anything about any of these. And this is why I think so many people feel helpless and hopeless about Alzheimer's. They know that, it runs in their family, but what are they going to do about it? And so many physicians don't realize that there are some very simple things you can do to reduce your risk drastically, but you can't change any of these. ApoE4 is a major risk factor. It's one allelic variant of an ApoE, a lipid transporter. 15% of us have what's called ApoE4. In this particular version of ApoE4, this lipid transporter puts us at higher risk. We don't clear amyloid beta as well. We'll get to amyloid beta. And in some cases as high as 12 times the risk of Alzheimer's disease. And your hippocampus, if you are ApoE4 positive, has an even harder time using glucose when you're insulin resistant. Yes?
So what do you consider ApoE2 for?
Sorry?
People who are ApoE2 and ApoE4, a 2-4?
I don't know. I didn't come across that. People who have ApoE2 are protected.
Right.
Relatively.
So because you have 2.
Yes. Yes.
So a lot of 3-4s are considered 4s, and 4-4s are 4s, but 2-4s, some people consider protected, and some people consider them an ApoE4. I'm just wondering if you had run,
No, I'm sorry.
It seems to be very controversial. That's why I was just wondering.
Oh, no, it's a great question. And one of the things you'll notice as you go through the talk, as a psychiatrist, especially now, I used to, but I don't work with Alzheimer's patients clinically now. So I'm sure a lot of you have information that'll be really interesting for me to hear during the talk and at the end of the talk, to put it in context for me clinically. As a psychiatrist, I hear a lot of people complain about their mothers. Here's another reason to complain about your mother. We inherit our mitochondria from our mothers, and it's interesting. Brain glucose metabolism in elderly people who have a mother with Alzheimer's disease is lower. And it's unclear exactly why this is, but some scientists have hypothesized that there might be inherited vulnerabilities in the mitochondria that are being passed along from mother to child. So insulin resistance is the most, in my opinion, the most powerful risk factor for Alzheimer's disease you can actually do something about. We know how to treat insulin resistance. This is not rocket science. And so it's really quite easy. 80% of people with Alzheimer's have type 2 diabetes or insulin resistance. 80%. And so it's an easy target. And it turns out that the degree of insulin resistance correlates with the more insulin resistant you are, the harder it is for you to use glucose. And this has been shown in a variety of different types of populations. People who have no symptoms, who are older, people with mild cognitive impairment, which is pre-Alzheimer's, ApoE4 positive people, and people with Alzheimer's. The more insulin resistance you have, the worse your glucose metabolism is, especially in the hippocampus and other areas of the medial temporal lobe. People with Alzheimer's disease have lower ratio of blood insulin to brain insulin. That's been shown in studies, and that correlates with the theory that the blood-brain barrier is becoming saturated and insulin resistant. You see it earlier in women. So just a refresher about where the science stands right now about the, how Alzheimer's disease develops in the first place. These are the sort of the three main theories that are out there right now, and there's a lot of evidence for all of them. We used to think that it was amyloid plaques that were the sort of initial injury, but it's the amyloid oligomers before they even form plaques, which accumulate. The formulation of neurofibrillary tangles, that begins with the glycosylation, sugar, and hyperphosphorylation of tau proteins. And when this happens, they detach from microtubules and start to form neurofibrillary tangles. And then mitochondrial oxidation and decay. Mitochondria, as the energy generators in the cells, these are key. Energy is everything in the brain. And so without enough energy, the brain starts to fail. So the reason why Dr. Suzanne Lamont of Brown in 2008 coined this popular term type 3 diabetes, started calling Alzheimer's type 3 diabetes, is because all of the disturbances that we think lead to Alzheimer's can be accounted for by insulin signaling problems. And I'll show you that in a minute. And if you use insulin sensitizing medications, you see cognitive benefit, at least in the early stages. So how does insulin, what role does insulin play in the formation of amyloid plaques? Amyloid oligomers are toxic to synapses, and they interfere with insulin signaling, furthering insulin resistance. Insulin's role is it reduces the production of amyloid oligomers, and it decreases the aggregation of amyloid beta. So if you don't have enough insulin, amyloid beta starts to accumulate. Neurofibrillary tangles, how is insulin involved there? Insulin regulates the phosphorylation of tau, and that's one of the steps to detaching the tau from the microtubules and beginning to form the neurofibrillary tangles. All of these features of Alzheimer's, from glucose hypometabolism to hippocampal atrophy, every one of these features can be explained, at least in part, by insulin's crucial role in cell metabolism, growth, plasticity, and survival. Literally, if you don't have enough insulin, your cells will die. Your brain will starve to death. So it's important to point out that type 3 diabetes is not just a consequence of type 2 diabetes. So not everybody with insulin resistance gets type 2 diabetes. Not everybody with insulin resistance gets Alzheimer's. And if it's unclear, there are really two different end stages of insulin resistance, two different organs being affected. Some people will be affected in their brain, some people will be affected in their peripheral metabolism, and some people both. So how much, when we talk about hypometabolism, what's the degree of that? It's 15 to 25% reduction in the amount of, in the efficiency of your glucose utilization. And this happens long before any symptoms show up, long before you have any memory problems. And this led just a few years ago to a new staging system that includes 2 preclinical stages where the person themselves has absolutely no awareness that they have a memory problem. Unfortunately, you can only see this on PET scanning or spinal taps. But this has been shown to happen long before the clinical stages of subtle cognitive decline, mild cognitive impairment, and Alzheimer's disease show up. So it's a very long process. In fact, it was chilling to me to learn that Alzheimer's disease is preceded by decades of glucose hypometabolism. And it's been detected in women as young as 24 years old. So this is where I hope my Smith students are really listening.
Is this detected just in a study setting, nothing clinical, right?
No, this was a group of women with PCOS, actually.
So how are they measuring this? How are they detecting the glucose hypometabolism?
With PET scan.
PET scan.
Yeah, sorry. Contrary to this wonderful body of literature we have about insulin and Alzheimer's disease, we don't know very much about how insulin and glucose affect mood. I have lots of hypotheses about how they are tied together, but it makes sense to think that if insulin resistance is affecting memory, the whole brain, well, mood, of course, is an important brain function. Many of my students come to me with a chief complaint of difficulty concentrating or remembering. It's probably the number one reason why they come in. They want to be able to study. They already notice that they're not concentrating and remembering as well as they used to even a few years ago in high school, they tell me. And so, I was just wondering if there's a link. So we know in the periphery that carbohydrates can be toxic over time. Hyperglycemia, hyperinsulinemia, and sympathetic overdrive. This can play a role, high epinephrine levels. This can play a role in panic attacks, insomnia, mood swings, and anxiety levels in general. But overall, what we're seeing is inflammation and oxidation throughout the body and the brain, it turns out. Sir Henry Moseley was a psychiatrist, a controversial psychiatrist back in over 100 years ago. Had the foresight to notice that, I love this quote, diabetes is a disease which often shows itself in families in which insanity prevails. He noticed that connection all those years ago. And it turns out he's right. So people with type 2 diabetes are twice as likely to develop depression, and people with depression are at higher risk for developing type 2 diabetes. There's a connection. We don't know what the nature of it is. This is just an association. And this way of thinking about mood disorders is in its infancy. There's a small but significant association between depression and insulin resistance, but it's really nothing to write home about. There's not a lot of data there yet. What about the hippocampus in depression? Our friend the hippocampus comes back, and he looks very depressed and stressed here. So in depression, you see smaller hippocampal volumes even before the first episode of depression. No idea why, but that is an association. The hippocampus is not just sensitive to insulin and glucose, it's also very sensitive to stress, the stress hormone cortisol, for example. And when the hippocampus is stressed, it's much harder for it to send out beautiful new dendrites and to generate new cells. And this is occurring as early as in the womb. So a stressed pregnancy can damage the hippocampus. And those with an emotional neglect history happen to also have smaller hippocampal volumes. So this can happen in childhood. There's a little bit more information about bipolar disorder than there is about depression. This was a cross-sectional study, a really good one in my opinion, done just last year in Nova Scotia, where they took 121 people with either bipolar type 1 or 2. Type 2 is the milder form of bipolar disorder. And they were sort of youngish to middle-aged. And they just decided to test them all for insulin resistance and diabetes. And they discovered a very high rate of insulin resistance and diabetes among this population. And some of these people had never even been diagnosed with diabetes, didn't even realize they had diabetes until they got tested in this study. And interestingly, the people who had insulin resistance or type 2 had a much worse course mood-wise. They had more symptoms for longer periods of time. They were more likely to be rapid cycling, to have in their mood. And what I found fascinating is that they were a lot less likely to be able to respond to the mood stabilizer lithium. And this correlated with BMI. The higher your BMI was, the harder it was for lithium to help you stabilize your mood. And there's an even stronger association between bipolar disorder and diabetes than there is between depression and diabetes. 3 times more likely to develop diabetes if you have bipolar disorder.
Do you think that's related to the medications, or?
No, that's medications aside.
Oh.
Yeah. Excellent question, though. One of the reasons why I think this is so interesting for me as a psychiatrist is that some of the medications we use to treat bipolar disorder actually worsen insulin resistance and therefore can worsen the course of the illness. The data on the hippocampus in bipolar disorder is not as strong as it is with depression. Some of the studies do show smaller hippocampal volume. But it's really unclear whether that is why so many students, especially my patients with bipolar disorder, there's a very strong, it's very clear that many people with bipolar disorder struggle more with memory and cognition than people with depression or anxiety, say. But it's unclear if this has anything to do with their complaints. So what can we do about all of this? You know, I think it was fascinating to me in reading all of these articles about Alzheimer's disease. I could, you know, for example, I read this 20-page wonderful review article specifically about Alzheimer's disease and insulin resistance, and in 20 pages there was not a single reference to dietary intervention.
Why are we not surprised?
I know. I mean, for anybody who's watching this online, I want to convey to you my surprise. You know, there were references to what drugs can we use to target these receptors, and oh my gosh, it was just so disheartening. Insulin resistance, we know what to do about insulin resistance already. And you know, they go down the same dead-end road that we've been going down with type 2 diabetes for way too many years, in that we think, oh, well, there's not enough insulin in the brain. Let's put more insulin in the brain. That's sure to help, right? And it does. It helps short term in all of these populations. But what is the problem with that approach? You're putting more insulin in the brain is going to become more insulin resistant. You're worsening the course of the disease. And you know, I just think it's a terrible state of affairs. I mean, the problem in Alzheimer's disease is you don't have enough, you have plenty of fuel, but you can't use it. And so we need to find a fuel that you can use that doesn't require insulin. And so some of these choices are not necessarily very useful, but I think ketones are, you know, sort of a natural choice. And there have been, you know, there are a lot of reasons to think that ketones, which again are the breakdown products of fats in a low insulin environment, if you're not eating too much carbohydrate, you can generate ketones. And I eat a ketogenic diet, so I know a lot about this. So ketone metabolism is simpler, it's cleaner, it's more efficient than glucose, and it's preserved in Alzheimer's disease. At least in the early stages, people with Alzheimer's disease can use ketones beautifully, even though they can't use glucose very well anymore. Ketones do cross the blood-brain barrier with their monocarboxylate transporter, as Brian explained to us yesterday, and there doesn't seem to be any hindrance of that, at least in early stages of the disease. There have been there were lots of animal studies, but I like to focus on human studies because we do have a few in Alzheimer's. Medium chain triglycerides, which are readily converted to beta-hydroxybutyrate. These are from coconut oil and palm kernel oil and things like that. They improve cognition. This was the very first study done in humans, 2004. Just took 20 people. They gave them either MCTs or heavy cream, and at 90 minutes they had higher beta-hydroxybutyrate, and they had improved scores on this, I can't remember the name of this test, the Alzheimer's Disease Assessment Scale Cognitive Subscale, which is a commonly used test to evaluate Alzheimer's disease. And if you were E4 positive, you didn't do as well, but if you were E4 negative, you did better. And then there was this was a randomized controlled trial, double-blind, placebo-controlled, multi-center trial done a few years ago, where they showed that medium chain triglycerides improved cognition in mild to moderate Alzheimer's disease versus safflower oil. And they watched these patients over 90 days. There was good improvement at 45 days, a little bit sort of dropping off a little bit by 90 days, but you know, their score on this test, which is a 70-point scale, improved by like 3 to 5 points, something like that. And that's without any dietary changes at all. And then there's a case report, a very interesting case report of a man, 63 years old, who had Alzheimer's disease for 12 years already and was having a lot of trouble functioning, like with ADLs and so forth, and independent living. And just by taking ketone esters, which are, you're actually taking ketones themselves, not the MCT oil, which gets transformed into ketones, took them 3 times a day and had significant improvements in his ADLs and ability to function independently. He did this, I think, for 20 months.
10 minutes.
Okay, great, thank you. I put this Band-Aid here because, again, I think these are very promising studies, and they tell us a lot about how the brain works, and they tell us a lot about Alzheimer's disease. I just worry that without the dietary changes, you still have a high glucose, high insulin environment. And I'm not sure that in the long term that's going to be as effective for you as dietary changes, or at least partial dietary changes in combination perhaps with ketones. And there's one dietary study in humans that was done just a few years ago of a low-carb, high-fat diet. So they took people, non-diabetic patients who had mild cognitive impairment, and they asked one group to lower their carbohydrate to about 20 grams or less, and the other group, they said, keep eating, your typical about 50% carbohydrate diet. And then they watched them over 6 weeks, and they measured their urine ketones, not their blood ketones. They said that was too expensive, which I can attest to. It is expensive. And they did better. There was some improvement in memory, a few points on their memory tests, versus the people who ate the 50% carbohydrate diet. One problem with this study was that they unfortunately asked the people who were eating the 50% carbohydrate diet to get all their carbohydrates from fruits and vegetables, which I'm sure was a change from how they usually eat. So there's a little bit of a double intervention going on there. The people in the low carb group, the degree of ketosis correlated with improvement, and surprise, surprise, they naturally lost weight without even being asked to, and they ate about 500 fewer calories per day just because their appetite was lower. They didn't restrict protein, they didn't restrict fat, they just said keep your carbs at around 20. There are no studies about depression and diet, to my knowledge, and this needs to change. There's one published, there's a couple of case reports in the literature, 2 women with bipolar disorder type 2, the milder form, who stayed on a ketogenic diet, in one case for 2 years, one case for 3 years, and reported that it was superior to medication for managing their mood symptoms. And in my own, when I used to have a private practice and did some nutrition consults in that private practice, I had a patient in my practice who was not responding very well to medication, was very motivated and was willing to try diet, which many people are not. And so she went on a low-carb, high-fat diet, and she made remarkable improvements. I mean, it was amazing, especially, I don't know how many of you know this, but it makes sense. Bulimia responds beautifully to a low-carb diet, beautifully. I've seen it over and over again. Because it controls your appetite and your urge to binge, and the cravings go away. And if you don't have the cravings, you don't binge, and if you don't binge, you don't purge. It's really, and there's nothing about this in the literature. In fact, the eating disorder literature is very sad. They don't talk about food at all. I understand that. So what I want you to take home from Scottsdale in your doggy bag, in your hippocampus, is screen for insulin resistance. We all do that anyway, I know. And we had a lively debate yesterday about how and what's the best way to screen for insulin resistance. And I wrote a blog post a couple of months ago about this, for the general public, how to diagnose it, how to treat it, how to prevent it, and includes this downloadable PDF with tests, a list of tests you can take to your doctor if your doctor's not savvy about these things, that you can ask for. And I came across in the literature this formula, which can be one of the things in your toolbox if you haven't seen it before, for estimating insulin resistance, and it's on the website too. It's just one. There's no perfect test. It's really I think the most important thing is just to look for it and do your best at having a sense of, does your patient have insulin resistance or not? And it's not about being able to perfectly tell them exactly where they are on that spectrum. And then included in that blog post is an infographic that helps people understand how to cut back on sugar and what other things they can do to improve their insulin resistance, such as exercise and, thank you, Daryl, specifically resistance training, and even reducing dairy intake, because that can raise insulin levels as well. I came across quotes in the literature about, let's intervene earlier. How about midlife? I mean, why wait until midlife? I mean, this is happening over decades, why wait until it's too late? I mean, I think the time is now. So that's the end of my talk. Thank you. Any questions? I don't know if we have time for questions.
We have questions, yeah, we have
Okay.
5 minutes.
Sure.
So my question is, and I've noticed this with my patient, and I have a close family member that just sort of where I can observe this more carefully, who was just recently diagnosed with early Alzheimer's dementia. And prior to this family member was pretty good with her diet, but as the dementia became apparent, the changes in personality with dementia made it so that she started cheating a lot on her diet. And it's very difficult to get her to follow a low
More
carb.
disinhibited, yeah.
Right.
Yeah.
Because she does whatever she pleases now.
Right.
And so I think this is great, but the question is, that's why the focus is on medications. What do you think about berberine, for instance?
I don't have any experience, and I honestly did not look at the medications because it wasn't my focus.
Right.
I wanted
I mean, it sounds like a great idea, but if they're going to, stubborn, and that's actually how we noticed that the dementia was really getting worse was with the personality change.
But you said that metformin, insulin sensitizing agents do show some clinical improvement in earlier moderate dementia.
Yes.
So
Yes.
berberine
She wouldn't take metformin. Yeah, that's why.
well, berberine is an alternative because it acts very
Yeah.
much like metformin in that regard.
And that's why I think the key is really early intervention and obviously prevention rather than waiting until it's too late, because once you're at that point, it becomes it's hard for anybody to change their diet, but especially
She was good with
somebody
her
who.
diet until
Yeah.
it got to that point.
Yeah. Daria?
Oh, it was a great talk.
Thank you.
2 questions. Let's see. First, I want to know if you've seen any reversal of the condition in terms of people getting back to more normal brain function if they're able to stay on a ketogenic diet. The second question was, have you observed any anorexic patients that benefit from ketogenic diet?
Well, two answers. So the first is all the data, the human data in clinical trials was in this talk, as far as I could tell. This is the extent of it so far. There are more trials being done, but what you saw is what there is.
Yeah.
In terms of anorexia, it's a fascinating. I have this hypothesis that a ketogenic diet could be really beneficial for people with anorexia, but people with anorexia are scared to death of eating fat. They are fat phobic, and it's really difficult. And the other thing about people with anorexia is very complicated. When you ask them to restrict something, you can trigger more eating disorder behaviors. So a lot of people with anorexia, when I say you really need to be careful with carbohydrates, you can eat as much of this or that. You can eat as much fat as you want, which they go, oh, I don't want to do that. But you have to be careful with your carbohydrates, and then they become very rigid and obsessive, and it can trigger more eating disorder behavior. Any kind of dietary intervention with people with anorexia has to be done very, very carefully because you can worsen the condition. But I do believe it's a condition of brain starvation, anorexia.
Dale Bredesen's work at UCLA with 10 Alzheimer's patients, he has 22 interventions, but several of them relate to addressing insulin resistance. So it's not the only thing he uses, a sugar and insulin resistance lowering diet, but 9 of his 10 had marked improvement.
Wow.
And have held it for 2 or 3 years. Yeah.
Wow.
Yeah,
The Journal of Aging.
temporary or long-term benefit.
Yeah, long term, and
Yeah.
it's holding, and he keeps updating it, that
What's
it's
his name?
continuing to hold and improve.
Thank you so much. This is a great lecture.
Oh, thank you.
So I wanted to mention just an N=1 study, I guess you call
Please.
Mary Newport.
Yes.
What if there was a cure for Alzheimer's and no one
That was that case report that of the 63-year-old man. That was her husband.
Yeah, and he had Alzheimer's as early as in his 50s, and it was heartbreaking because it was so severe that he couldn't even qualify for an experimental drug called Kedison. Turned out Kedison was actually medium-chain triglycerides from coconut oil, and it's now under the name Axona. It's still a medical food, but I guess the criteria for passage for FDA for medical foods the bar is fairly low. But she estimated that it was about 2 tablespoons of coconut oil a day that contained the same amount of medium chain triglycerides as in the experimental product, which is now Insulin. I think that's a really nice do no harm approach.
Yes, yes.
To just give an elderly patient 2 tablespoons. I don't think it could hurt unless they're allergic, of course, but it might help.
Absolutely, that's a great point, and I wish I'd thought to say that before, is that if people can't follow a diet, they're in the early stages or they don't want to follow a diet, the ketones are certainly something you can do if they can't change their diet or don't want to. Yeah.
Was there anything in the literature around insulin sensitivity and physical activity?
I didn't come across that in the Alzheimer's literature in particular, but in that blog post that I wrote a few months ago about insulin resistance, there's a lot of information particularly about resistance training in lowering blood sugar levels and improving insulin sensitivity as you build muscle cells. So it's the most efficient way to do it is instead of walking or even running. Aerobic is not as helpful. It's good, but it's not as helpful as resistance training, strength training.
Thank you.
Yeah.
It was a great talk.
Thank you.
I understand that the use of dairy fats is controversial, and I think that part of it is that unless you're using ghee, there are a lot of proteins remaining in the dairy fats. But do you have any information, or have you come across anything that talks about dairy fats in particular? Of course, certain types of fats have different effects, and we're learning that there's an entire universe of fatty acids and lipids and phospholipids and glycolipids and et cetera, what besides the medium chain triglycerides do you know of that are helpful, and is there anything specifically harmful about the dairy fats? And I noticed that one of the studies that you put up there compared heavy cream to heavy cream plus the MCT oil.
Right.
So I wanted your comments on those.
Oh, great. What I can say, I can't answer all of those excellent questions. What I can say is that I have looked into dairy in particular in terms of its effect on metabolism in general, and I can tell you that the natural growth hormones in cow milk, this is without any added hormones. I mean, milk is a growth formula for a baby cow, so it includes lots of naturally occurring hormones that stimulate our insulin systems, stimulate our IGF-1 receptors, and raise
now,
insulin
these hormones,
levels.
are these peptides or are these lipids? And in other words, are they removed in the process of clarifying butter?
That's a good question. I don't know.
Because hormones are typically peptides, but
Yeah, they are proteins. The growth factors in.
So they're water
hormone
soluble, so you wouldn't necessarily see them in the fat portion then?
No, if you clarify.
You see them in the cream, but not the ghee.
Yeah.
It's clarified, then you're going to be safe.
Because I know that whey protein raises insulin levels just as much as sugar does, basically. And so it just puts insulin is a growth hormone, it puts your body in growth mode, which you don't necessarily want beyond the age of 1 or 2.
I was just trying to find out, what's actually in dairy fat, and do we even know?
When I've looked more closely at it, because I've had this question myself before, I looked specifically, where are the hormones in the milk? Are they in the fat portion? Are they in the, and I know they're in the whey portion, but I couldn't find anything about heavy cream, for example. So I don't know. If anybody comes across it, I'd love
certainly
to.
steroid hormones like vitamin D or like the sex hormones, the gonadal hormones
Would be the fat soluble.
So it's interesting. I'm just curious. I mean, I don't expect you to know either, but
no, it's a great
something
question. I
wonder
wish I
about,
knew more about it.
I looked into this as well, and the arguments that I got when I kind of threw it out there was that the stomach acid basically takes care of those proteins. But I don't know if that's really true, because the whey also, I've read that it does have insulinogenic properties. So.
And also, I mean, cows have stomach acid too. So I'm like,
Yeah.
I don't know I don't know what to do with that.
I didn't either. I just thought
That's great. That's really interesting. Yeah, it sounds like we need to learn more about dairy.
Okay.
Oh, thanks, Rick.
Thank you.